Good morning, everyone. My name is Crystal Lander. I'm the Executive Director of Global Affairs at Pathfinder International, an organization dedicated to sexual and reproductive health for all and working around the world. And it is really my pleasure to be here today for part 2 of our conversation around decolonizing global health, perspectives from nurse and midwives. And thank you to our organizers, See Global Health, Frontline Health Workers, IntraHealth International, for organizing this amazing part 2, and we will have a part 3 that we'll talk about later. Our first conversation was so robust. We got a lot of feedback from people saying, we want to hear more, we want to learn more, we want to know how we can be better. And I just want to start this conversation with the point of, this is about being better. No one has gotten this down perfectly, but we know that we can deliver global health better. We know that we can partner on global health better. We know that it takes the full community to do this. So it's okay to ask questions. It's okay to say, I don't know, and get for tips after. We just really are really grateful. So in the chat box, you will be able to ask questions there, and we'll go through them as we go along and toward the end. We also will have the social media tags for you to continue the conversation online. We want to elevate this conversation as much as possible. Our nurse and midwife leaders will share their perspectives on what it will take to deconstruct the narrative, the structures, the policies that perpetuate social inequality, including racism, colonialism, sexism, and problematic power dynamics inherent to global health. So we are back with our fabulous panel of experts who I can't wait to talk to again. Judy Canola, who is the chair of the Center for Nursing and Midwifery at the University of Global Health Equity. She's a recognized nursing leader with over 25 years of experience in clinical nursing and education programs. She's led HIV programs and provided technical support to NGOs and the public sector, working with partners, ministries of health, and multiple countries in East, West, and Southern Africa. We have Margaret Phiri, who's a nursing and midwifery advisor at See Global Health, where Margaret is a nurse and midwife by training who collaborates with key stakeholders in Malawi and beyond to strengthen and improve equity and quality of nursing and midwifery education, practice, regulation, leadership, and research for improved health care outcomes. And we have Michelle Drew, President of the Black Coalition of Safe Motherhood and Executive Director of Ubuntu, Black Family Wellness Collective. Michelle has a unique insight into birthing while Black and the role that systematic racism plays in the health of Black mothers and families. She uses that understanding to empower clients and advocates for increasing the diversity of perennial workforce and expanding access to Black midwives and doulas for Black birthing people. And again, we are so excited to have you all here. Ladies, let's just jump on in. First question, and I want to start with you, Michelle. In what ways has racism, colonialism, and sexism shaped global health in terms of our practice, our policies, and our programs? So Michelle, you talk a little bit about our practice. You're on mute.
First of all, just thank you again for arranging this. This is wonderful. So in clinical practice, both for the client and the midwife, it shapes who is the midwife and who is that person that's taking care of you, especially when we're seeing people who are coming from colonial countries coming into colonized countries. So in the United States right now, 86% of nurse midwives are white women. And it's not an accident because, our profession has only really existed in the United States for less than a century. And it began with the premise that Black women and Black nurses were not simply incapable of taking on the job of being a professional midwife because of our Blackness. In Great Britain, you had a system, for example, where the National Health Service was built by Black midwives from the Caribbean and then phased out. So today, the workforce, it looks like that. And in clinical practice, if you are a person of color, the chances of you seeing someone who looks like you, who speaks your language, who understands your culture, who can provide you culturally competent care, culture is very, very low. And it also means that there's a lot of times that, the people who decide who become midwives, nursing educators, I tell people all the time that they're essentially the gatekeepers. So if you've been socialized to believe that Black women, just by virtue of being Black, are somehow less intelligent, then how are you really treating them as colleagues in the workforce, or are you even helping them enter the workforce? And when you go abroad, working with an NGO or someplace where your job is now to like teach, educate, empower, if you come in with this colonized notion that you are superior simply because you're Anglo, then your default premise from the beginning is wrong.
Yes, you started. Yeah, you're getting us started early. I love it. Judy, pick up on these points a little bit from the programmatic point of view. So we know in the practice what we see, but in the programs and the designs and all this, everyone is well-meaning. What happens with the program part?
Same thing that Michelle has said so correctly. First of all, unidirectional engagement, where we have the flow of resources is coming from the premise that rich countries are giving the poor countries. So the fortunate are giving the less fortunate. So this has come through because of colonialism in Africa, and this has informed the programming of many of what happens now. So in Africa, right across from the north to the south of Africa, all the programs that we have, which are aid dependent, come from the global north. So we have programs that are dependent on donor funds. These donor funds are often in the high income Western countries. So already just that is wrong. And then now you come into how this aid is played out. So first of all, I have worked a lot for many years with NGOs and aid programs where there's a lot of duplication. So you have one aid donor coming, let's say from the US, let's say USAID, and then you have from the European Union, you have EU funds. So you have USAID funds, you have EU funds. They're doing the same thing in Kenya. But because they don't talk to each other, what they implement is disjointed, is fragmented. Now, in fact, we have more and more of these. So we have Japanese coming in with JICA, we have Chinese coming in, we have French coming in. We've always had the DFIDs and all these coming in. So first of all, when they come into the field in Africa, the way they play the game is already disjointed, which means that the trickle-down effect for the people they're supposed to serve is diluted. That's number one. Number two, these programs are finite. So you have a USAID project, which is 5 years. So it comes and it implements something for 5 years and then it leaves. What happens? Okay. Then we have projects, even during implementation, and I've been part and parcel of this, where in the middle of a 5-year project, it pivots, it changes. So I was part of a project that was primarily nursing, but then because something changed in the United States, a government regime changed, all of a sudden the funding is like, oh, no, we don't care about nursing now. We're looking at HIV. So all this has to do with HIV. Nobody asked the recipients on the ground. Nobody talked to the nursing schools. Nobody cared about what the country needed. And so all of a sudden, this money that was supporting something is just pulled out and done something else. I just want to talk about the nomenclature quickly about, when we look at programming, these words that have come in the last 20 years, capacity building, north to south, LMICs, HICs, developing world, developed world, first world, third world. We have donors, we have recipients. When I look at myself as a recipient, inherently already, even just the language that is used makes me feel like I am less. When we say, oh, we are going to do capacity building, I actually had a title of capacity building advisor in one of the projects that I worked in 2010 to 2013. That was my title, capacity building advisor. So that means Africans have no capacity. That's inherently what you're saying, that we do not have any capacity. I want to look quickly at things around when you look at programming and you're saying, what happens when you have a finite 5-year project for 5 years? So what happens then? Then this agenda of these programs, who sets the agenda? So I have sat in rooms for hours struggling to write a proposal to USAID in the United States, to NIH, your National Institutes of Health, to CDC. which is the donor, which then gives money to Africa. And they'll put the parameters. They're saying you have to do this, you have to work with so and so, you have to do this. There is no, at any point, interface with the people on the ground. If we're talking about nursing and midwifery, hardly will you find a nurse or a midwife, much less an African nurse and an African midwife, part and parcel of that programming that then comes to ostensibly help the Africans. I'll stop there for now. Crystal.
Judy, you're on a roll. Like I said, I love the enthusiasm and the energy and the passion, to be perfectly honest. We want to get this right. We want to do better. Margaret, can you talk a little bit of like, how do we get there? So Michelle and Judy are talking about what's happening at the end, but some policies are in place. How come we can't get these policies right so these things don't happen? Or maybe they've always been this way? What are your thoughts on that?
Thanks, Crystal, and thanks, Michelle and Judy. I think my colleagues have said it all, especially in terms of programs, in terms of interventions. As you know, policy is at the center of all those. It's the policy direction that dictates, that determines what needs to be done. Therefore, in our countries, especially in Africa, whereby policies are still based on colonial legacy, based on those who have got the powers and those who have got money, normally do not respond to the needs of the nation. The real needs that need to be addressed. And that is why you will see that the health responses in our countries is slow. Sometimes we even feel like we're not doing anything, but we're doing a lot. But because of the policy directions, which might not be correct, the effects and the results of that are really detrimental. And especially that these policies, most of the time, they focus really on imported ideologies, on things that may not really be very important for specific countries, but they're important for them, those with monies, because they bring in their own agendas.
Yeah.
So if global health has to change, then we really need to work hard on coming up with policies that are indigenous, policies that are developed by those who understand the needs and the systems of the people that we're serving. And I can't wait for the day when we'll have that power and say so, just to say, you know what, these policies are not going to be any helpful to us. I think, let me stop there.
That's great, Margaret. And it really takes us into the next piece, because I mentioned earlier when we were talking that I remember being in the audience and hearing Foreign Minister Agne of Rwanda say on a stage with the head of USAID and said, no, things in Rwanda won't happen this way. We have a plan, and if you don't want to focus on our plan, then we don't want you in Rwanda. We don't want you doing research. And I remember that you could hear a pin drop, because I had never heard anyone say that before from a country. Because let's face it, a lot of these programs are based on kind of a savior mentality. And that's what I want to get into a little bit is, many of us weren't here when these programs started, but we are part of a system that somewhat perpetuates this idea of someone's coming to save, and all the knowledge, Judy mentioned this, all the knowledge is in, the global north, moving to the global south of if, we're training people, building their capacity, all of these words that we don't really realize are rooted in some sort of superiority complex. So starting with you, Margaret, how can we change this? What can we do to change that, since the system was built on something that wasn't that great to begin with, and now we're trying to improve? We know lives have been saved. We know all these wonderful things have happened, but we want the system to be fair. We want it to be empowering and supportive. What are some of the things that we can do based on the history and to where we are now? An easy question.
I think I think, Crystal, one of the things that we need to do is to be courageous and confident and say exactly what we want. Poor or rich, this is what we need and this is what we would like to see. Of course, that comes with two things. One, we have to be able to take the risk and say, we should not go at the expense of our own health. We should not do this at the expense because somebody is saying things that are not correct in terms of, oh, you're doing well when we know we're not doing well. So if we are honest with ourselves and committed to the core of change of our own health and health systems, I think we can do it. I would rightly say that. Also, I think our government should take that responsibility, take that lead, and do exactly what you just gave as an example, Crystal. There are a lot of partners who come and they just run the agenda without even taking into consideration, even bothering to say, what does the country want? What is your plan? Where do you want to go? But to them, because they have the money, then they dictate. And because we are powerless, we don't have the money, we don't have the power to say something, we just accept. But it's true, I've also been to some countries, like Botswana. They told one of the famous organizations to say, if you don't buy this, get out of here. And I just hope all of us are going to say that.
Wow.
Not because we don't respect that, but because we want these decisions to be mutual. We have to feel they've got a purpose for us and that they're here to help us and not to help the legacies that were created before we are even born, some of us. Thank you very much.
Absolutely. Judy, over to you on that. Like, okay, the system, we know it's the system that was based on colonialism and white supremacy in many cases, but how do we pivot now? How do we change this narrative a little bit of Black and brown people need to be saved around the world and really get it to more of equality focused?
I think, first of all, we need to do what we're doing now, and we've started well, and that's first have the conversation. First of all, we need to understand what is wrong. You cannot fix something if you don't know what is wrong. All the things that I've explained are symptoms of, a deeper problem, which then manifests itself in various things that everybody can see something is not right, but they just don't understand exactly what is it that is wrong. So I think what we're doing today, this afternoon, what we've done in the past and hopefully we'll continue to do through these conversations is begin to talk about these issues. And the people who need to talk are not just the Black people, the white people as well. White people often sometimes either through whatever issues don't want to confront this issue, or sometimes even say that, this happened in the past, colonialism, it's only actually 60 years ago. In fact, in Kenya, it's less than 60 years ago. So let it go, accept and move on. So first of all, understanding the inherent challenges that we face. Today, I'll give you a very stark example. We have the WTO, World Trade Organization, Director General. The front runner is an African woman. She's Nigerian. Her name is Dr. Ngozi. But the US has blocked her appointment to be the Director General, despite the fact that she's got all the votes from the rest of the world. It struck me, and I just wondered, even as I was preparing for this webinar this afternoon, is it because she's Black? That would crossed my mind. Also, is it because she's a woman? That's another thought that crossed my mind. So again, looking at things properly from the lens of what they are. Some things, sometimes people jump to say it's racism, it's because I'm Black. I've thought that sometimes when it's happened to me, my own personal life, but maybe often it's not. So again, beginning to have these conversations. It's important, I think, like Margaret has said correctly, to strengthen the structures that are in Africa. Africa cannot continue crying. We can't be crying every day about certain things that went wrong. We can recognize them, we must recognize them, but I think first of all, the aid mentality has made Africans lazy. It has made African leaders lazy. It has made African governments lazy. They've absconded their responsibility. So for me, the fact that this aid has come to do what the African governments and leadership should do, to me, I would really actually want to look at a different mechanism and literally look at, let's stop this aid and stop Africa being dependent on the West and begin to find our own solutions to the challenges that we face today, that often are as a result of what happened yesterday, but we cannot keep crying about it and need to find a fundamental way forward that's good for us as Africans. So we ourselves have to be on the driver's seat to drive our own destiny as Africans. Like I said earlier, if a program ends in 5 years because the West said it's a 5-year program, USAID came in and said, this is a 5-year project, it starts in 2020, it ends in 2025. And all the projects we implement have all these M&E frameworks, and they have all these work plans and things, and by year 3, you have to start looking at how you're going to hand over, etc. We have seen that this is not working. We need to now sit and say, hey, this hasn't worked. What's going to work for us? And number one is just moving away from aid dependency, moving away from that donor type way that the world is currently built around.
That's great. And Michelle, bringing this over to the U.S. side, we still have the same things. It's not lost on me that, you know, we still are very connected, these Black and brown communities across the world, and bringing it home a little bit. You still are dealing with this right here in the United States of kind of this top level, maybe seen as low level education, knowledge around the role of Black midwives. And so how do you, if you told us earlier, the system was based on basically thinking Black midwives weren't good enough, or Black people weren't good enough to be midwives. How do you still build on that? And I know you're doing a lot with education, but like, how do we get that system to be better based on a system?
You know, one, I think you just have to intentionally push back, right? And as uncomfortable as the conversations there are to hear, I often hear from midwifery educators, especially program directors. I hear from practice directors when I ask them, how is it that that you have a program, a midwifery program that, can hold, whatever, 20 students, and 20 of them are all white. And part of it just has to be willing to have uncomfortable conversations. Here's the thing, it's not been that long. We're really talking about, especially from the graduate, university level of education for nurse midwives in the United States, we're talking about 60 years. I mean, a little more than my lifetime. And when it began, every director was white. Today, there are 39 midwifery programs that educate midwives. And 35 of those directors are white. One is a man, 34 white women. There is one Asian midwifery director. There are 2 African-American midwifery directors, and there's currently one interim who is a lovely West African sister. But that's not, and so I often tell people that if you may not realize that you have been socialized to believe that simply because I'm Black, I have less intellectual capacity, because that's always been the narrative. You've been socialized to believe it. So when you receive that application for a midwifery student, and in the 21st century, many graduate programs actually require a photograph along with your education, with your application. I had to submit a photograph to go to graduate school. So despite the fact that I was a Phi Beta Kappa, that's a big deal in the United States.
Yeah.
Despite the fact that I graduated first in my class from every degree that I've ever had, despite the fact that I already had a master's degree in public health and had done malaria research that, was published in peer-reviewed journals and international, I had to go and prove to somebody that I was a good fit. And I had people predicting that I was going to struggle. And so, if you have been, so if, educators aren't just educators, they're the gatekeepers. You decide who gets into your program. And so until you acknowledge that even if you're not racist, you're not living your life on a structure of white supremacy, but this whole structure was built upon that, and are willing to make an intentional effort to dismantle it, we can't get anywhere. Because it's very uncomfortable to hear somebody telling you something that says, turns out that I'm a racist. That's not what we're saying. We're saying that the system was built on a premise that Black folks were less capable. Like, that's how we decided the African slave trade. This is how we built the Western civilization. And so if you have been socialized and you've been taught the same rhetoric that's been passed down for 500 years that says Black people have smaller brains and therefore we're less capable, or because we're poor and went to bad schools, we're not going to succeed, you keep that, in your subconscious. And it does affect, because, one of my primary jobs as an educator is to make sure that everybody who I graduate passes their boards the first time. So what if I'm just concerned that if I admit too many Black nurses into my program and they don't pass the boards, my pass rate will go down, my job will be threatened. So, not only, the primary job of educators often is simply to make sure that they're going to get people in who are going to graduate and pass the boards. They're not trying to fix it to make sure that we're actually getting justice for the women we serve. In the United States, 8% of the last time it was counted nationally, midwives attended 8% of the births of Black women, only 1% of the births of white women. Now, white women made up 50% of the people giving birth, and Black women made up 15% of the giving birth. But when you add that together, what that means is 2 to 1. The women that are being attended by a workforce that's 86% white women is overwhelmingly Black and brown. And so that also goes into how you treat your patients, because if you default believe that they don't have the intellectual capacity to understand healthcare, are you teaching them? Are you giving them informed consent? Are you letting them make informed consent or refusal? But you've been colonized to believe, you've been trained to believe that just because, we somehow have this less gifted intellectually, that we can't be trusted. And so we really have to be rigid about rethinking our paradigms. And I think we also have to think about where we're putting the money. Right now there's 4 new programs that'll come on board in the next few years from nurse midwifery education programs in the United States. All of them are in places that are predominantly white. We have a robust population of historically Black colleges and universities in the United States right now. Many of them have nursing programs. There is not a single nurse midwifery program at an HBCU right now.
Well, you're hitting on a point that's my next question around how do we reclaim this legacy of midwifery that's really rooted in African context. And in the US, and I'll kick it off to you first, in the US, and you started with HBCUs. Historically Black colleges and universities not having these programs, they graduate the highest number of, Black students in the country. So what can we do? Why aren't those programs there?
Exactly. The reasons that the last 2 programs that were at HBCUs have been gone for 10 and 20 years respectively, and neither of those programs was closed because of poor performance. It's really important for people to know. Like, both of those programs in their era produced more Black midwives every year in a single year than all of the other nurse midwifery programs decided combined. So, and I think it comes back again to almost like a decolonization or reparation matter. I think, tomorrow the federal government should fund nurse midwifery programs at HBCUs. There need be another nurse midwifery program in the United States that is approved until there is a single program at an HBCU. And because it needs to be run by Black folks for Black students who will serve Black communities. And it also ties in to what Judy and Margaret were saying. Even when it comes to funding and programming, we talk about aid, I'm talking, you know, so when I went to a predominantly white institution and I was awarded a scholarship that, by the way, I didn't actually need economically, I was supposed to have my hands out and say, oh, thank you for your charity. How would that look different if I'd been at a historically Black college and university where everyone was there and everybody's going to work hard and you're going to hustle, but you're going to do it. But everybody assumes that everybody there is capable. And then when we look in the global health arena, we talk about aid, and that aid comes with white supervision and white advisors who tell you how to do it, because we're sitting here with our hands out and saying, thank you for this assistance. I will submit that every country that benefited from the African slave trade every year for the next 100 years should give 1% of its gross domestic product into a fund that would allow the global health to be run by Africans to do their own programming. Because if you've raped this continent for 400 years, it's not fair. It's not unfair to ask you to give back for 1 year. And those countries that didn't directly benefit from the African slave trade still got some benefit from it. So maybe they should give half, like 0.5%. But put money in there and let African specialists in global health and African program directors and African midwives who know the needs of what's happening in their country talk amongst themselves and have this fund managed. And between Nigeria and South Africa, you have two of the fastest growing economies. I'm pretty sure there are economists and health experts who could help the funds be used well. And let African countries figure out the issues that they need to figure out. And it's time for us to step back and say, we're not actually the saviors. We're the creators of this program, of this problem. And you can't be both, the oppressor and the savior at the same time. So maybe it's time for me maybe it's time for me to step back and say, you know what, I wronged you. I want to do something to repair it, and then let the people who know best what's needed, whether it's in inner city Detroit or in Nairobi, Kenya, figure out what needs to be done to improve the health of Black birthing people.
Great point. Judy, how do we reclaim midwifery and nursing? Oh, you're on mute.
You're muted.
Yeah, sorry. Just to add from quickly what Michelle is saying correctly. It's amazing that the face of Africa is made up of Western celebrities. The face of Africa is Bob Geldof. The face of Africa is Bono. Often, sometimes Bill and Melinda Gates. Western celebrities form the face of Africa because they paint a picture to the West, which now, unfortunately, for those who don't know any better, swallow it wholesale. And it's, in fact, we call it the horseman, the four horsemen apocalypse: poverty, war, corruption, disease. That's the face of Africa. I remember when I was about 14 years old in 1984, there was USA for Africa, and there was this whole, people came to sing for us, and Michael Jackson and Lionel Richie and all the Western celebrities were singing because Africans were dying of a famine. So while I don't have a problem with emergency aid, because that happens anywhere, even emergencies come and that we can stand together at that particular time. I have an issue around the government to government aid that we get that is skewed and that is still very much, as Michelle has said correctly, oh, thank you very much for giving me this cup of tea and now I can sleep because, my savior has come. So I think we need to very deliberately move away from that, specifically related to nursing and midwifery. And I'm in the field of education, nursing education and midwifery. Is first of all, we need to just change the way we do things. So one of the things I think we can do, we are 13 million nurses in the whole world at the last count, the last time I checked, and 13 million of us can change the global thinking in nursing. So first of all, stop looking at the whites as being the owners or the people who are the experts. Even within Africa, I even actually wrote this down. A white nurse is always seen better than a Black nurse. If I walk into a room and I am Judy and there I am, I'm in my nursing uniform and I'm coming to do a procedure for a patient on the bedside, and a white nurse walks in, you'd be shocked I probably have higher qualifications than that white nurse. But even the patient in the bed will think that the white nurse knows better than I do. I could even be the supervisor of this white nurse, but everybody, the patient included, will think that the white nurse is better than the black nurse. So we need to begin to do what I call reverse innovations and start taking things together, collaborating, the global north and the global south, that there is knowledge in Africa. We have to recognize this. There is knowledge inherent in Africa. Colonialism came and made it that when the colonialists brought in the Western style medicine, they erased the African narrative, the African way of looking after sickness and sick people. African practitioners actually in the past, pre-colonial, didn't used to look at the disease. They used to treat sick people, not a disease that the Western biomedical model brought, which started looking at diseases. And because of that, they fractured and broke the African way of doing it, that even us who now, like I went to nursing school and did my nursing education with that Western biomedical lens, threw away the African aspects of it. It's actually been theorized that the reason Africans go very late to get medical help is because of this biomedical Western model that was brought in by colonialism, where the African is sitting there and thinking, they're going to prick me with a needle and draw my blood, and the medical lab technologist or the nurse or the phlebotomist is telling him, I'm drawing blood to check your blood glucose, because that's the Western biomedical model. But from my own African perspective, for example, I understand other factors that are affecting my health. And so this needle that is intruding and drawing blood from my body doesn't make sense. And then I'm being given this wonder drug that's come from Pfizer or from wherever, GlaxoSmithKline, so on and so forth, which has not cured me. And then I come tomorrow and I'm still given this drug, which still hasn't cured me. And after some time, what happened to the Africans? They stopped 100% believing in this Western medicine because it was distanced from their own African cosmology and the inherent African medical knowledge that we have. My grandmother, my mother, my auntie, that has been passed on in midwifery, in childbearing, in sickness, in broken limbs, in malaria, and so on and so forth. I want to ask a quick question. Why has malaria been eradicated in the global north? I got malaria. When did I get malaria? I think it was February. I got malaria. Me, Judy, I got malaria. And I'm like, why? Why? And yet there's so much money. We have the Global Fund to fight AIDS, TB, and malaria, which puts in millions of dollars in Africa. But we have failed to, and I don't think that's because we don't have the knowledge, So, number one, we need to start sharing knowledge. We need to recognize that each one of us, West and, the global north and the global south, has inherent value to give to each other. We need to begin to be sensitive to the African cosmology, our ideals, our values, our tradition, our knowledge, in medicine and in health, that can come to bear towards putting an Afro-sensitive lens to the global issues that we face. We need collaborations and partnerships. Earlier this afternoon, we just launched.
Judy, you're already getting into your final points.
Sorry, let me
That's
stop
okay.
there.
No, but you brought up some good points, and as you were talking, I thought it's some of the exact same things that you're saying. We're talking about the U.S. too, where we have, particularly in the Black community and in the South, people are saying we don't trust medicine. And it's been slow for the exact same reasons you said, because it doesn't feel based in maybe truth or in our history or whatever. But so I see a lot of symbolism. And I just was in a conversation with someone at a Rotary Club meeting where a woman from Africa said, well, I don't understand. Why aren't we focused on eradicating malaria rather than having bed nets? And it was a simple question. And I was like, that's a really good point. Why haven't we eradicated malaria? Margaret, I'm going to come to you, and then I'm going to take a couple questions online. So how do we reclaim the legacy of midwifery and nursing, again, based on the fact that we know the system was broken, we know based on colonialism, but how do we do that?
So I was muted. I think just to add to the points that my colleagues have said, if we talk about Africa, maybe some some people do not know how we are trained, and especially as midwives. You know, a midwife or a nurse in Africa is trained in such a way that she's supposed to function where there's no doctor. And in our healthcare systems, our doctors are very few. And it's really the nurses who are manning the healthcare system on average. If you look at midwifery, the training that we do, that we go through, we can do deliveries of twins or breech, any of those complicated deliveries, we are trained to do that. So we really have the opportunity to reclaim our legacy. Of course, working with our colleagues, but really we can be the drivers of change, and especially if we think of from bedside to the bedroom, to the boardroom. Because you see, it's the nurse, it's the midwife that spends almost 24 hours with the client, 7 days in a week, 365 days in a year. We have all the lived experience that we can share to the world, to the other colleagues to say, no, maybe let's do it this way. The thing that we lack, I see most of the times, is the confidence and the change, the courage to make a difference, because we can. And I'm very optimistic that we're getting there. We are having a number of nurses and midwives who are really well educated, well informed now in Africa. And especially if you look at Southern Africa, and look at my own country in Malawi here, I don't know how many nurses have got PhDs and masters. Same thing, South Africa, wherever. People who have the potential to make a difference, to reclaim the legacy. So to all my colleagues, working in partnership with our professional colleagues, let us be the drivers of change, and we can do it. Let us keep on architecting the programs, nursing and midwifery programs that are responsive to the needs of our people. And I think we have the opportunity to do that.
No, this is great. And I think you all are getting and addressing some of the questions that I saw in the Q&A. And for all of you, we talked about aid, and that aid will be, you know, particularly USAID is seen as the operator of our aid system. But people said of the donors in general, I mean, because it's a lot of donors globally to this work. Have you seen any changes from them? And this is a question from our audience. Have you seen changes? And someone gave the example of Haiti. Have we seen any examples of the aid community, donor community, addressing some of these problems and getting better? Margaret, I think you started a little bit with leadership, and I think last time we discussed a bit on books and education. But have we seen, you know, anybody doing this right or getting better when it comes to this? Margaret, I'll kick it off with you.
I think we are doing better. And I think the world, or the donors, or the people who have come to help us are also realizing that we mean business and they respect us, and we're doing it. Because if we look at most of the national programs, I think nurses are there. They've been given the responsibility to give direction in program implementation. That in itself is a trust that they have, that nurses and midwives can do it. Not only that, I think also what happens most of the time, I want to touch on what Judy said earlier on, is one has to be clear about what are the issues that we're addressing here. And with our education, I think we're getting better and better on that. We're understanding our past, we're understanding our present, and we're really determined to chart our future, to chart our destiny. So we may not be doing it 100% perfect, but I think we are trying to really come on the floor and say, no, based on the evidence that we have, based on our experiences, again, from the bedside to the boardroom, these are the real things that happen in our settings. Can we change the policies? Can we change the programming approach? And I think
it's getting better.
Yeah, getting better.
So Judy, are you seeing changes from your perspective between the donors? I know, again, we talked a lot about education, and that role just stuck with me so much. You and Michelle talked a lot about what we're teaching, what we're handing down, what books look like, language we're using, the impact that has. but do you think some of the donors are picking up on this? I mean, I know we have a lot of NGO partners online and nursing programs online. The fact that they're even here, to me, sends a message in the right direction. But tell me from your perspective, are you seeing some changes?
To be honest, if they are not so much so that you can feel it. And I think where we are in 2020, that to me is sad. Yes, I want to say progress has happened in terms of, from me as an African, education. So Africans are now more educated. But that education has now made what has happened to us Africans because of the education we received, and I must add here, Western style education. I have gotten a very Western education. I become middle class then. That's what happens to me, Judy, because I'm educated. So now I have a good job. Margaret is sitting there at Seed Global. She doesn't earn 2 shillings. She's very well paid, I'm very well paid, averagely for an African. So then what happens? I want to maintain the status quo, okay? So I'm middle class, I might take my kids to schools, I live in a nice house, and so then I don't want to rock this boat, okay? And because of that, change is not gonna happen. And I'm frank, Judy, I sometimes say I'm also part of the problem to some extent, because I can talk theoretically like this in the webinar and say all these wonderful or not wonderful things depending from where you come from. But what is it that I need to do as Judy, you see? So I think that's what, as Africans, we need to start asking that hard question. Now that we're in 2020, we've gotten here, we are educated, we are understanding, we have knowledge, we know the dynamics, we know everything that's happening. What can we do? When I talked about Dr. Ngozi from Nigeria being mooted to head the World Trade Organization and being blocked right now by America because Americans have their own agenda, which I guess Dr. Ngozi is not going to align herself to, coming from a developing world and wanting to push the agenda for Africa. Someone actually said, you think Americans care whether a farmer in Nairobi, Kenya, or a farmer in Lilongwe or Mzuzu, Malawi, is able to sell their coffee, their tea on the open market compared to a farmer in, I don't know, Arkansas or Texas or wherever it is in America? No way. So I think for me, we Africans have to solve our own problems. So we have to start that hard conversation of starting to solve our own problems ourselves and not looking to the West. The whole aid thing to me does not work. We have to kill it somehow and build another structure that is not this aid dependent structure where, actually I'm told that the aid that we get like from the United States is maybe 1% of the US GDP, which tells you it's a lot of money because the American GDP is huge. But it just tells you where on the priority they are. We are what they give us 1%. It's like a token. Oh yeah, Kenya. Let's give you
1%.
Yeah. So
oh yeah.
Even that in itself tells you something. Regarding concrete things that we can do from the education perspective, we can change the curriculum. We can begin to build nursing leadership across the board, and not just in a few countries in Botswana and South Africa, but everywhere, including Sierra Leone, Liberia, Francophone Africa, Lusophone Africa. These things are not happening there. You won't find Mozambicans here because they can't understand English. So who is talking to the Mozambicans? Who's talking to the Angolans? Who's talking to the French in DRC and in Cameroon? These are the questions, these are the hard things we need to start really articulating and saying, who is that Margaret? Have you seen her? Have you heard her? Can you speak to her? Can you say her name? No, because we don't even speak to each other as Africans because of those language barriers. For me, these are things we need to begin to look at. Somebody says there's a London School of Tropical Hygiene Medicine, tropical medicine.
Hygiene, yeah.
Why do we have tropical medicine? Why? It's inherently racist. It's because Africa has been taken out of the whole world and put somewhere. There's something peculiar about Africans and Africa and their climate and their people that we need to have specific things. Do we have a center for temperate medicine, temperate health, or polar health?
Wow, that's dropping some knowledge here on us, Judy. I had not thought about that. Again, you all resonated with a lot of things. Language matters. Michelle, I want you to jump in on this, and then I'm going to do a last round, which is a question that's come up of what do we want to see? What does it look like? What would a decolonized global health system look like? Before we go to that, Michelle, for you, again, what are some of the things we should specifically do for, I mean, aid in the US is different. In the US, we don't quote unquote get aid, but we still have a responsibility. We have states and funding and different things. What do you want to see happen from the government perspective on these issues?
Well, we do have aid in the form of philanthropy because, I run a nonprofit organization whose goal is to serve disenfranchised Black, birthing people in America, and I rely mostly on funds. But, often if I apply for grants from different philanthropic organizations, they want to tie their aid to making sure that my program addresses their agenda. And the thing that I think of that's most pressing, that's an easy example, is contraception and abortion access, because, one of the, if not the largest funder in the United States and worldwide of healthcare for the disadvantaged, recently wrote a book about, and it included in 2019, the notion that Black women in Africa could be lifted out of poverty if Black women weren't so fertile. So just by, if we give everybody a LARC, we give everybody an IUD, then suddenly we'll resolve poverty in Africa. And I get that here too, that, it's like, okay, it's great that you want to offer open access to healthcare. It's great that you want to start a nurse managed medical home that is intentionally staffing Black healthcare providers to serve Black health women, but I don't see in here where you're talking about making sure that everybody has access to LARC and child spacing and et cetera. So when you ask me, is it getting better? The answer is no, because we still, even in the era, we watched George Floyd murdered in real time on Memorial Day. We've watched the Attorney General of Kentucky not even bring charges for Breonna Taylor's murder. And yes, people are now outraged and saying, okay, Black Lives Matter, but in the C-suites and in the dean's offices, we're not saying simply by default, Black educators, Black clinicians are equal to white clinicians and white educators. And that's where, and it has to start with with people who, whether it's the government or whether it's, the Gates Foundation, you cannot tie your money to your agenda. So I get a lot less funding than I could, because I often tell agencies that, like, I've presented you my proposal, I've laid it all out, you'll either fund it or you won't, but what you're going to do is give me, this Black woman, this money to serve those Black women, and you're not going to tell me how to do it. You're going to believe that inherently, with that CV that I just showed you, and with this grant application, that I know what's best. And you'd be surprised every day how many people will say that I'm not going to fund you. And I'm like, well, then great, and God bless you. And then, from the government standpoint, there was this year introduced a group of bills called the Momnibus Act, and it was specifically around Black maternal mortality. And there were a number of bills that included things about maternal mortality review and those things. But one of them, to me, that was the most interesting, was one that was called the Perinatal Workforce Act. And the only purpose of that act, from a community health worker or a doula all the way up to the highest trained obstetric specialist, is to actually bring Black people into the workforce. And unapologetically. And that's what needs to happen. Because if we're not willing to admit that a medical system, a nursing system, a midwifery system that was built on white supremacy and segregation, you cannot just simply make a couple of tweaks, that you really have to dismantle it and rebuild it, or you have to start a whole parallel system. Then, if you're not willing to make that basic assumption, then how can we get anywhere? And it's why medicine is, frankly, at least in obstetrics, has done a better job, because HBCUs produce, like, I can't remember the statistics, something like 75% of doctors, Black doctors in the United States, have some tie, whether it was undergraduate medical school or fellowship training, to a historically Black college or university. So we know that Black people do well when they're in settings where there are other Black people. that support them. So when I take racism and white supremacy out of the way, turns out that Black people can achieve.
Wow. Okay, we are nearing the end of time, and I want one last word from each of you. Tell me your one thing that you would do first for, in your perspective, for a decolonized public health system. And Judy, I want to start with you. What's the number one thing on top of your list needs to happen first?
I think we need to have chief nursing officers in every African country with a dedicated budget to deal with nursing issues. And that chief nursing officer must be a nurse or midwife.
All right. And I rushed you on time. This isn't my last question, but go ahead, Margaret. Same question. Margaret, you're on mute. What's your number one thing? And then I'm going to really go, we're getting a lot of questions in, so I want to make sure I get to these audience questions too. But what's your one thing you would change?
The one thing that would change is to really build capacities of nurse leaders and other health professionals at every level to be strong advocates and change agents of decolonization of global health based on their lived experience and collectively taking it forward.
Great. Michelle, what would be the top of your list?
I would actually tie, like funding of programs that aim to talk about diversity, equity, inclusion, or health disparities to an actual look at the internal diversity of that organization. If your organization is led by all white people and you either have no Black people or only a few tokenized persons, if your only Black leader is the diversity, equity, and inclusion officer, I'm not going to fund you by default, because you can't tell me that you're ready to center Black people in health as healthcare recipients and as healthcare consumers if you're not there to include us as colleagues.
Wow, that's a huge point. That hits home with me because I remember it was a foundation that gave money to an organization I work for. And toward the end of the year, during a report, they came around and they were like, well, we want you to self-identify your ethnic group. And I was like, okay. And I was filling it out. And at the time, I was like, that's so weird. But I love, and then they organized it, people of color or ethnic minorities. And then they said, what position did they have in the organization? And the reason why it was important was they said, if they didn't feel like your organization had diversity, they were not going to fund you. And I was like, people do that. That was amazing. I don't know if they do it anymore, and other organizations, I don't know how to pick that up, but that's a key thing. Last time we mentioned the role of boards for NGOs in particular. They have the power. They put people in place, or the fake leadership positions where, like Michelle hinted, whereas like if the only people of color are in positions with HR or maybe diversity, but they don't have any power, they don't have direct reports, we see that a lot. So it's this faux sense of inclusion. But I want to get to these questions, and this is kind of a rapid round of questions. One question is, thank you very much for the session. The question is, are leaders here willing to partner with us and join our pool of nurses who are willing to share knowledge on how we can learn from one another? And this was coming out of Uganda for the nurse healthcare conferences in Uganda. And I'm gonna, put that over to all of you. Would you be willing to be a part of these consortiums, these meetings on healthcare and nursing? Margaret?
Very willing to be part of that team. And as I said earlier, together we can do it better, and together we can achieve more results. So Great. Let us link up and give us the details, and we'll be part of you. Thank you.
All right.
Absolutely.
Judy?
So absolutely.
Great. And Michelle?
100. When do you want me there?
This is great. So we wanted you to hear that loud. Another question, a number of people agreed and said they think the aid system isn't working. It really isn't based on that. But coming off of the question, a specific question was asked was, do you think it's better to give government to government funding, or is it better to go through NGOs and other organizations? And I'll put that out to whoever wants to start answering that first.
Government to government funding is the one that is not working, and is the one that's contributing to the problem that we've talked about this past 1 hour around donor dependency and the in fact nowadays it's called dead aid. The fact that $1 trillion was put in Africa in the last so many decades, and we've seen really nothing that you can point your finger to. And passing this through all these NGOs and things, I don't think is right. I think, to me, that Africa, I'm talking specifically here for Africa, African governments need to create a climate where people can come and invest, because Africa has something to give the rest of the world. If we open it out, people can come and invest, put mechanisms in place that allow for the investment. And when this happens, the economy grows, and then we are able to then have social justice and equity. I can just give, if I have time, one quick example. Ethiopia has, I think, 100 million people, just that one country. I think it's the second largest populous country in Africa after Nigeria. It has only 2% mobile telephony penetration, only 2%. And why? Because the government is rigid, that bureaucratic, and has not opened it out. Now, if this one country can open out investment in mobile telephony and digital communication, in and of itself, they'll be able to generate money for themselves without even asking for 1 shilling from USAID or so and so. And you'll be shocked that the health budget for a country like Ethiopia is 90% donor dependent. I worked in Uganda for 16 years. I think the Uganda health budget is funded almost 100% by donor funds. So how has that helped the health system for a person in Uganda as we speak now? So for me, that's one of the areas that we need to begin to think about.
Good point. Michelle, thoughts?
Yeah, I think that just predicates like the whole paternalistic ideas that, especially from the US side, we see it like, it's either the carrot or the stick. As long as you dance and do what we want, we give you money, but if you don't, we withhold it. I think direct allows all of those strings to be tied until it's just one big knot. That's why I think there needs to be a global fund that's given and then administered by folks in Africa for Africa, just like I think in the United States we need to fund Black women-led organizations, Black nurses, Black midwives, and like if you can't start with the premise that in the year of our Lord 2020, with my years of experience, a background in public health, proven leadership and education, that I'm capable of developing a program, then, I don't even really want your money. But we have to get out of this because, we're still in the 21st century, living with a presumption that African countries, or in the United States, that Black people and Indigenous people are default less qualified.
Oh, okay. And then Margaret, what about you? Any thoughts on the best way for this aid to get to programs around the world? Is it better government to government? Oh, I may have lost her. Okay, we'll come back to her on this one. And as somebody who lives in the US who works for an aid organization, I always feel obligated. I champion these things in congressional offices. And I argue very much that the US role in the rest of the world is to be a good leader. And I take it from the perspective of we took a lot, and therefore we should be giving back a lot. But I like the idea with Judy of, we know the current system isn't working. So we have to figure out a better system, and it may be the investment system is a better way. I know a lot of people like the different model of having a resource and countries. It's a partnership model of countries being able to get requests the things that they need for their system, all the while, of course, advocating for more domestic resources to go towards health in the country. So we have to get on a better system, and I really hope we can do that soon, because as you all noted, it is not quite working the way it is. Another question someone asked is, how many midwifery and nursing books are written by Africans and published in Africa? And I will put that up to start with you, Judy, on that one.
I can check, but I can tell you they're probably less than 5 for the whole of the nursing and midwifery population that we have in Africa. It's very sad. It's a very good point.
And Michelle, in the US, do we have books written by Africans used in, by African Americans, Black Americans used in our schools and our programs, even in, predominantly white schools and programs? How can we change that?
Unfortunately not, and we really need to, and it's interesting in the United States now. I originally trained as a midwife. I'm a registered midwife in Zambia, and so the Bible was Miles', textbook for midwives, and the African version at least had some African contributors. In the United States, sort of the Bible of midwifery, which, by the way, I didn't read and still passed the boards, is a book called Varney's Midwifery. And the contributors are overwhelmingly white women, and many of them, like much older. So there is no acknowledgement. And the most recent edition only recently started including history, about the history of African Americans in midwifery. And it was like fighting tooth and nail, and actually took a lot of painstaking protest to even be included in just a few pages of the book. So yeah, we need to actually start writing our own narrative, and including just the fact that, midwifery, just like medicine, the first formal midwifery schools in the world with actual texts, with an actual discipline, were on the African continent in Egypt, 5,000 years ago. The first formal medical schools in the world were on the African continent. Hippocrates, learned a lot of what he knew from studying ancient Egypt. So if we're not willing, we should just move forward with understanding that the midwifery workforce that was eliminated just 60 years ago, actually, they weren't ignorant, because they were functioning on a 5,000-year-old tradition. And when I think of it this way, is that if I am coming from the West to the United States, from the United States and going to Africa, I have a lot to learn, because there is a tradition that's ancient. And I should be sitting at the feet of people to learn who have a 5,000-year history of expertise in healthcare, because, or formalized nursing and medicine in the United States has existed less than 2,000 years. But yet before the English language was written, there were medical schools in Africa.
Those are great points. Margaret, you're back. We're glad to see you. The question that we had for you, well, now we have two. One is, we talked a little bit about aid and donor priorities and different things. What do you think is the best way to support programs, countries in Africa? Is it government to government, or is it going through NGOs, a combination? Judy mentioned and more investments in Africa. What are your thoughts?
My thought on that is that I think maybe we should be promoting the combined models, and what should really be emphasized for both is the aspect of accountability systems. That whatever monies we get, we all need to know what that money has done and what have we benefited from it. So that part has to be made very, very clear in our government system. And also, I think those should be known right from the beginning, even when it's donor to NGO, they should be looking at the capacities, so that part of that money should be helping to build those capacities, who will then be able to be accountable for the funds that are given. I'll look at it from that perspective.
That's great. One question that came up, and one of the questions I had, is what does a decolonized public health system look like? And I know this is a hard one, but we know that the end result is that things will be better. But what does it look like in terms of the structure, institutionalization, partnerships? What does a decolonized system look like for public health, and particularly as it relates to nursing and midwifery? And Margaret, I want to kick it off with you.
You want to start with me?
Yeah. What are your thoughts on how will we know success? What would this look like if they're not to say it's going to happen overnight, we know we didn't get here overnight, but what would that system really look like?
As we know that global health, or decolonization of global health, aims at promoting justice and equity. Now, we would only know that we're doing something if people have voice in what they're doing and in what they've been given. They understand the issues, they make contributions, and also they ask questions if they're not clear. So in this aspect, what we're looking for, we hope that with this decolonization agenda, our education systems will be better for nurses and midwives and everybody. We're going to receive aid that is responsive to national health needs, and also that our governments too are going to be accountable for the funding that they get from the donors.
Great.
That's what I mean.
Judy, what does this decolonized public health system look like?
I think for me, it's at different levels. And if I look at it from the structural level, I would say stop the aid dependence. Let's just stop the aid flowing in from the West. At institutional levels, like where I sit and where I work, we need to review our curricula. We need to infuse our curricula with African thinking and African cosmology. We need to begin to advance the nursing agenda within Africa, which is looking at advanced nursing practice, specialty nursing education, standardization of our education so that what defines what a nurse is, and shed off the colonial tags of certificate, enrolled, and have a unified thing that says in order to be a nurse in Africa, this is the entry point, and then this is how you progress, and these are the ways you grow your career and profession. We need at the interpersonal level, for me, is even have conversations with nurses and ourselves as nurses with our colleagues, doctors. One of the things I was reading is that even the rivalry we have between the disciplines, let's say nurses versus doctors, is also a throwback or an inheritance from colonialism, who brought this Western biomedical model. So again, we need to start talking to each other across the professions and having sincere and deliberate and authentic conversations. We also need, from a personal level, myself, yourself, and all of us, to just decolonize our minds and begin to think about, what does it mean for me to be an African now in the 20th century? Yes, we had colonialism. Yes, that happened. But now that we are in this year of our Lord 2020, what does that mean for me to be an African? And I think for me is not throwing out everything, but let me say, taking, the wisdom from the Western, medicine, but then infusing it with that African cosmology, being sensitive and responsive to that African cosmology. We need to deliberately invest in nursing, definitely. Like I said, we need to have the collaborations between the North and the South, and we need our health systems in Africa to change. For me, one of the very concrete things we can do in Africa, at least for the countries that I live and work in, like in Kenya or Rwanda or Uganda, is have that at the community, maybe up to tier 3 of our health system, run by nurses, because we don't have these experts at the moment. And nurses live and breathe and work in the communities and are very much part and parcel of the health that they give because they live in there. So changing this hierarchical and hierarchies is one thing we can do. Stop this thing of every head of medical services in Africa is led by a doctor. It has to be a medical doctor as head of, director general of WHO, head of this, or head of director of medical services, and begin to just allow and open the space out to other health professionals. There are many, but off the top of my head, these are some of the things I can suggest.
I love it. Michelle, how do we do this in the US? I mean, I feel like it's hard in Africa, but you gave some really concrete examples of what we could do to start. In the US, I feel like it's a whole different situation, but we're, parallel in the same position. And I will say, one caveat is, as you were talking earlier, I thought about it. Never once did I think about necessarily a midwife being Black, because every midwife I've ever seen was white. And I mean, I'm a Black woman growing up. I have a public health degree, been in public health most of my career. I never saw or feel like been connected to a Black midwife until I was much older as an adult, probably working in Washington, D.C. So I feel like we have similar, it's just so many similar positions in this. So how do you do this in the U.S.? How does this decolonized system look like in the U.S.?
You know, it starts with understanding that culture matters, right? Number one. And, you know, I will contend that, you know, when I get invitations to speak, or for example, on something regarding health disparities and Black maternal health disparities, and I look at the rest of the panel, if the person who isn't facilitating it, and if, you know, the majority of the experts on there aren't Black, then I'm not coming, because, you know, it has to begin with the fact that we are the best experts on what is needed to correct this problem. And maybe even taking it even a sad infantile step back and at least acknowledging that we're capable and competent and that we belong there. So for me, a decolonized health system will not be when, you know, 80% of births that are intended, you know, by attended in the United States are attended by physicians. You know, there will be a flip. 80% of births in the United States would be attended by midwives, because 80% of women are healthy and capable of giving birth without surgical intervention. And then when the people who are actually birthing Black and brown people look like them. But that begins also with leadership. And it begins with philanthropic organizations and our government who are funding education programs and who are especially funding studies that talk about reducing healthcare disparities, respect community-based public health, and acknowledge that Black women should be leading those programs.
You hit on a question that came up, and I think we didn't get into the research as much, but we've kind of hit, you know, brought it up at different points. Research and presentations matter. And I know the partners on this event, we've worked together a lot, and I know we've made conscious efforts to have representation, because we know representation matters. So I'm so glad you brought that up. A question that came up was around a student, a Palestinian American medical student, who says, I'm worried about being part of the savior complex and contributing to colonialism. And, you know, Judy, you know, hit on it. It's like, we work in this field too, and we still have to make sure we're not contributing to the stereotypes and all these other things. What would you give one advice, Judy, of how not to be a part, you know, end up part of the system, the way, you know, inadvertently sometimes it happens?
I think for me, and I can't even pretend to have answers, because like I was even saying, I think sometimes I'm part of the problem, but then here we are, we're in a system that's there, and sometimes this is what we have, you know. But I think one of the things we can begin to start, and this conversation like we're having today is a good place, is to sit and rethink and reimagine stuff and the whole global health thing, and how can it work for both the global north and the global south? What I completely disagree with is this thing of aid. It hasn't worked. It's clear it hasn't worked. I live in Africa. I'm a recipient of this aid. And I can tell you right now, where I sit right now, even with this corona and COVID, patients are sleeping on beds, you know, in rural villages in Africa without mattresses. They're actually sleeping on a bed, just on the springs of the bed. That's the lucky one. Most of the others are sleeping on the floor. You talk about midwifery, Michelle, you know, and you speak from it from a Black American perspective, and you guys have problems. I do agree completely. But you have not slept in a hospital like Pumwani in Kenya, where 4 women are sleeping on the same bed, or 2 women are sleeping on the bed and 2 are sleeping on the floor. And I have nursed patients, we used to call it floor nursing, meaning I'm nursing a patient sleeping on the floor, you know, lying on the floor. So it's so clear to me that the aid is not working. So now that this is being said, we need to dismantle the structures and start the house and build the house again. The house is broken or has been vandalized, has not been functional for many, many years, and we cannot continue like this. Perhaps God brought Corona as a, you know, what do you call it, reboot, reset button for us to now begin to shape a different narrative. And some of the things I mentioned earlier are what are the areas we need to focus on. So yes, focus on the health workforce as a nurse, yes, nursing and midwifery, but even for me further, African leadership. Take our governments to account. We need to ask hard questions to these governments we elect. And sometimes I'm even feeling we need to stop electing these African leaders and elect new leaders. Literally for me, I think we just need a whole new crop of leaders. And if some of us nurses and midwives, the 13 million of us around the globe, can put ourselves up for leadership positions, I would vote for you because I know you understand what it is that I need. So maybe those are some of the things we need to start thinking about. Literally think outside the box.
You sound like the U.S. election system here. Vote them all out. Margaret, what do you think here? Any thoughts?
I know that Judy is very radical and also Michelle, but I just wanted to say that I liked the part that she talked about taking our leaders to be accountable for their governance. And I think that's a fact. I was even trying to look at the definition of what is aid. Aid is helping somebody. It doesn't mean they have to run our governments. I don't think that's the way things should be understood. We have to feel the sense of responsibility that these are our people. We need to do something for them to be where we want them to. Yes, we can ask for aid, and we should have the right to say we don't need that aid if that aid is misdirected. So I think here, maybe what would be key, if they can't do it that way, but at least give them an ear to say exactly what have you come here to do. And I know that most of our governments have also put in place some mechanisms, swap programs, sector-wide approaches, just to make sure that any aid that is coming from outside is fitting into the program of the country. Those are the things that we should be promoting. And really getting empowered and accepting our shortfalls and our strength that we have and building on the strength that we have. Thank you.
Perfect. And one other question I wanted to bring up is, if, again, for a lot of our NGO partners are on the line, if you could tell them a couple things to do to improve what they, how they are partnering with organizations in Africa, or how they're delivering their aid programs, what would be some of those things you would say? Judy, I'm going to start with you.
I think one of the things I would say is that we need to just rethink aid, and I don't think aid is the right structural mechanism to bring about the health equity that we all seek. And so I think we need to agree or come to a point of that understanding, and then reshape the narrative around this aid. And again, I'll keep on saying this: it is not the fault of the West, it is the fault of us in Africa, who have condoned corruption, which has been actually a direct result of this donor funding has been corruption. And therefore, because our governments are now lazy, our governments have absconded their responsibility. They know that, oh, we have money coming in for HIV, we have money coming in for TB, we have money coming in for malaria. So there are no homegrown solutions for that. They're like, let's wait for Bill and Melinda Gates, for, I don't know, PEPFAR funds, and I don't know which funds, and global securities funds, and all of that. And so then because of that, nobody is thinking, nobody is actually looking and saying, how do we begin to do things for ourselves? I mentioned in the last webinar that vaccines, life-saving vaccines and medicines, 80% of medicines in Africa are made outside Africa. How come we can't have a mechanism that allows for us to develop our own medicines? How come we don't have a mechanism that allows us to develop our own vaccines? These are the hard questions we need to ask, and it's only ourselves who can answer and come up with an answer that works. Corona came, and because of Corona, Africans now have started manufacturing ventilators. Why didn't we do this before? Kenya now has a homegrown ventilator for 500,000 Kenya shillings, which is like $5,000, but we've been buying ventilators from the West for upwards of $100,000 and more.
Yeah.
And now because we can't get them, we now make them ourselves. Kenyatta University, nursing and medicine students made a ventilator, and it's available now for people, you know, in the ICU. So these are the things I'm saying we need to have, and what's blocking that to me, I think, is our African governments and our African leadership.
Well, you answered a couple other points. What people said is aid caused a lot of corruption. And I think people think corruption is directly like someone stealing money, but corruption is you're not doing what you're supposed to do with the money, or you're bastardizing the money, or you're, you know, so it's more than stealing pocket. And I think people have in their image of, you know, let's put more parameters around how that money can be spent. But what it is that we need to ensure that it's getting to the people it's intended for, which is just as corrupt. Margaret, let's, I want to switch yours to a little bit of the policies. You have WHO, you have African Union, you have Africa CDC. These are more policy organizations who are supposed to help with coordination and different things. Do you think that they have helped? And what role do you want to see them play in these conversations that we're talking about today?
I think they have tried and they're doing a good job. They may not solve all our problems. I would make reference to WHO, where I was for quite a number of years. WHO is actually representative of African countries, or countries I should say. So what countries say is what WHO responds to. Even these other organizations, if I look at my own country here, to say the truth, they have given the edge. It's just that maybe, I don't know about our priorities, which is another thing. How are our priorities set? How are we guiding this donor aid that we're getting from people? So we can only get the best out of what we have been given if we're clear of the issues ourselves, in terms of where do we really need the resources to go. So I think these big organizations, they're still continuing to help a lot of countries, and most of the countries too are members to those organizations, and I think they do appreciate the support that they're getting from them. Thank you.
Great, and I will end it with Michelle. Michelle, what do we need to do? I mean, what do we need to do as a, you know, as being a part, and I'm saying we as part of it, what do we need to do? What do you want to see happen in the U.S. and what can we learn from, frankly, other countries on what they're doing?
Like first, one of the things we need to do is that not assume that the people who hold the wealth are really the experts. We need to learn to listen, and starting at the community level, at the person level, what do the people most impacted, especially when we're talking about maternal mortality and maternal morbidity, what do they think that they lack? And to listen to the people who are, the best experts. So, how often does it happen when a grant application is sent in and it's like, okay, well, these are our priorities, and you have to write your grant application around the quote donors. So first of all, I think, and I'm with you when we talk about aid and donors. I agree with Judy 100%. I don't call, when people ask me what I'm asking for reparations. I'm telling you that you've had 400 years. You had 265 years of free Black labor. And then you've had 150 years of greatly discounted labor. So I'm not asking you to give me aid because I need it. I'm asking you to put back into the community that you took from for 400 years. And if we are the funder, whether we're the funder in the United States or whether we're the Western funder who's now looking abroad, go, sit, look, listen, and ask questions. Because, I can write a grant application that will blow your mind, that will put all your buttons, but at the end of the day, if I have to do a program and the only way you'll fund it is for me to do it your way, and I know that your way isn't the best way, you've wasted a lot of money. You've wasted a lot of money. And that's why in the United States today, it's more dangerous to give birth in Alabama than it is in Rwanda. You know, that's why today we spend years and years and we keep funding grants over and over again that talk about healthcare disparities or talk about diversifying the workforce. And I mean, we talked about diversifying the workforce, and what did we do? We gave federal funds to predominantly white institutions to diversify the workforce. And it didn't work. But yet we have a whole education system around historically Black colleges, universities. We have Native colleges. We have colleges and universities in the United States that specifically serve Indigenous Americans, but we don't fund them and strengthen their capacity and say, maybe if we strengthen the capacity of these two education systems, that could produce people who look like the community which we're trying to fix. Maybe that would work. Not a single one of the native universities or colleges has a midwifery program. So we need to rethink it, because if all we're trying to do is put money into the system that already benefits from all the power and say we'll pull one or two of the poor unfortunates in, it's never going to work. The people leading these programs should look like the people that we say we're trying to serve, whether it's as nurses, midwives, or as birthing people. And
Michelle,
if we're not willing to let them lead.
Sorry. Well,
yes,
now I
we're
would
not
say that's the
let them
perfect
lead.
note to end us on. And you all, as always, been amazing. We will have a part 3 for everyone online already asking. I want to thank our speakers, Judy, Margaret, and Michelle. Thank you to Nurses Lead, Midwife Lead, Campaign Partner, See Global Health, Frontline Health Workers Coalition, the G4 Alliance, InterHealth International, Nursing Now, Partners in Health, and Smile Train. Thank you so much for bringing us together a second time, because it's so much to talk about and so much to unpack. And we appreciate it. We appreciate you all who are online, who are taking notes. And I can see you on Twitter saying you're learning and getting some real tangible outcomes of what to do next. And next time we'll give you even more opportunities to ask questions. So come forth. This is what this team is here for. We're not blaming. We're all talking about how we can do better, and we means us too. So thank you for letting me moderate your discussion. I learned so much while I'm here with you all, and I'm just as passionate on how I can be a part of the solution. So thanks so much.
Thank you.
Thank you, everybody.